some questions, to please start putting those through on the chat function below, and hopefully Dr. Lee can start answering them. Anna, I know you can hear me. Do you have any questions as from yet?
The first question is that what is the largest distance irreversible damage from the electrode? It depends on the tissue character, because we can't calculate that exactly, but in myoma, if we see the hyper change in the ultrasound, in myoma, if there is no echo change, but the irreversible change will become in that area. But in adenomyosis, there is a quick change, but there is no complete ablated in that area, because the content is a little bit different in adenomyosis and myoma. So it depends on the situation. If that is not completely ablated, then it's still burning, because there is still water content in there. But if it completely ablated, then there's no response, even if we use more thermal dose.
Dr. Lee, I don't know if you can see the questions that are coming up here too. There's one about avoiding uterine artery.
Frankly, we don't have to worry about bleeding, because if we insert the electrode tip, then not just remove, we ablate that area and then remove. So if we penetrate the small artery, but if we ablate that one, then it closes, so it doesn't make bleeding. So artery bleeding is, we don't worry about the artery. We don't have to worry about the artery bleeding. In RF myoma, ablation could be done as office procedure. Yes, it can be. I have a one-day hospitalization, but in many office clinic do that without general anesthesia. They do with just intravenous anesthesia with propofol, and discharge within 6 hours. So no general anesthesia, and we don't have to do the hospitalization. What size of endometriosis, adenomyosis can be ablated, such as less than 12-week size? In some cases, there's a huge size, but they didn't. The patient doesn't feel the discomfort of the mass effect. Then can try to do that, because the important thing is what the main reason for the procedure. If there's heavy bleeding, there's any symptom related to the bleeding, it can be treated with myolysis. So it doesn't. The size is not important. If the size is a little bit big, but the main symptom is bleeding, that is a good indication. But if the main symptom is mass effect, then the effect is decreased. So always think about the main symptom, not the size. If RF is done via vagina, how to avoid injury? What is possible risk? If you see the electrode tube with the ultrasound, if you can see the whole needle with the ultrasound, then there is no risk. But if sometimes we forget that little tip. That if we can't find out that needle, then we should not start the ablation. If we penetrate the bladder or bowel, it doesn't make problem. But if ablate someone, that area makes problem. So you have to always check about the needle tip by ultrasound. That is very important. What is the effect on RF1 calcified fibroid? Calcified lesion doesn't ablate it. But the myoma, no whole myoma is calcified. No, there is some part of calcified, and there is another is not calcified. So another calcified lesion area is curable, but the calcified area is not effective in myolysis. How to prevent sigmoid colon or small intestine injury of RF myolysis by ODHC? Frankly, I use bladder filling and bowel bladder filling with normal saline, and insert the sonogale into the rectum for prevent the injury. Because if the sonogale is inserted in the bowel, then it has a cooling effect. So if there is some heat will be throughout there, but it doesn't make damage because there's a cooling effect in the by the sonogale. And adhesion, you can check the ultrasound. You can find out that the adhesion area with the transvaginal ultrasound before operation. If you when you see the transvaginal approach, transvaginal ultrasound, and push them and back, push them back, and then if there's some adhesion area, adhered area, we can find out that there is adhesion or not. So if there's severe adhesion, of course we have to avoid that one. But normally we can find out that preoperative ultrasound about the adhesion. I don't know, but the severe adhesion we can find out. But a small amount of adhesion, then I think we can sometimes we can find out, but we have to check the safety margin. Then it can be safe. Could you define the side indication for myoma? It's normally maximum is about 8 cm. Well, normally it's about 3 to 8 cm is the suitable size for the myolysis. So what is the advantage of RF over endovascular management? I think that is for the embolization, maybe.
Yeah.
Is it?
So sorry, I'm looking at a nice question here, which I've heard quite a few times regarding uterine artery embolization and how that maybe compares to ablation generally. Could you please elaborate on that a little bit?
The advantage of myolysis over embolization is first preserve the fertility, because embolization, in the case of embolization, the ovarian artery can closed by the material, so the ovarian function is decreased. That is one. And two, so frankly, there is pain. There is many pain in the post-operative embolization, but myolysis is that the pain is suitable, not severe. Due to benign nature of myoma, is it necessary to achieve the complete ablation? Yeah, that is benign, but the regrowth is mainly done in the peripheral area. So if miss the peripheral area, then the regrowth can be happen. So that's why the complete ablation is important.
Thank you. Maybe one more question or so, if you have time, Dr. Lee. I think we're getting close to our end.
What about the round ligament fibroid? If the myoma is outside of uterus, and then the myolysis is a contraindication. But it's a little bit different. If the myoma is in the anterior part of the uterus, that means we can approach by a percutaneous approach. If it's possible, then can do. But subserosal myoma is a contraindication for the myolysis.
So look, I think more and more questions are coming in. I don't know how you feel, Dr. Lee. Maybe slowly we can wrap it up, and maybe if there's any more questions, we can do that by email. Is that okay with you, Doctor?
Okay.
Okay. Well, I think I'm gonna slowly then wrap it up. Dr. Lee, thank you so much. That was a really nice lecture, very clear, and I want to thank everybody for being with us today. Fantastic attendance. And any questions you have, please email Dr. Lee or one of us from RF Medical. We are very happy to answer these questions. And of course, we really hope to see you in Seoul some point soon to see cases with Dr. Lee himself. So again, a huge thank you to everyone. Very happy to see everyone here today. Thank you, and wishing you all a great day. Take care. Bye-bye.